It is my great pleasure to introduce Professor Fixen from the University of Colorado School of Pharmacy. Oh, I'm speaking quite loudly for a reason, because the microphone's over there and the microphone's over there. If you wish to speak, talk about as loudly as and obnoxiously as I do. It is my great pleasure to introduce Professor Fixen. Professor Fixen wrote an article for Humana that caught my eye, and I contacted her, and she has been so gracious in coming up here from Denver, if I remember correctly. So, without further ado, let's give Professor Fixen a big round of applause for her efforts in coming here. And Professor Fixen, the floor is yours. Please don't speak as loudly as I do.
Okay.
But speak
loud enough.
Yeah, speak loud enough.
Okay, great. Well, I'm so honored to be here, and I've lived in Colorado now for a little over 5 years, and I was originally born and raised, did all of my schooling in North Carolina, moved out to Colorado for residency. So I finished pharmacy school, and then I decided that I wanted a little extra training. I wanted to go into a special area of pharmacy, which required a residency. And so that residency led me to Colorado. And coming from North Carolina, we have no marijuana. At the time, we had no marijuana laws whatsoever. The only time that I'd really ever, been in contact or even been around marijuana was typically at concerts or things like that. And so, so moving here to Colorado, it was a completely different experience. And when I was in my training, I realized that a lot of the patients that I was caring for and the providers that I was working with, they had a lot of questions about marijuana. So, they had patients who were coming in saying that they had used marijuana for, pain or for a migraine, and they didn't know if it was safe, is it effective? And so me, being naive, but also wanting to learn more about it, I just kind of dove right in and did a lot of research. During one of my years of residency, I did a research project on the use of marijuana in patients with migraine headaches, and that received a ton of press. I was contacted from all over the U.S. just with the results that we found. And ever since then, I've just, tried to keep up to date with all the literature out there. And now in my practice, I specifically work at a seniors clinic. And so that clinic is with patients who are 75 years and older. And so as you can imagine, patients have a lot of pain. They have a lot that they're going through, and they've tried a lot of medications, some, without any effect. And I feel like a lot of their next steps is, should I try marijuana for what I'm going through? And so currently in my practice, I work with patients who would like to try marijuana for pain or maybe for agitation or behaviors. And so I just want to share a little bit of background for those who may not be as familiar with marijuana and the different cannabinoids. And then I'm going to go through some of the evidence. Unfortunately, just a disclaimer, there isn't a ton of evidence out there just because of the regulations. Marijuana isn't FDA approved. It's still a controlled substance, and so there are a lot of funding issues, but there have been some studies that are reported, and we'll go through that today. So if you want to move to
your slides.
Yes.
So this always takes more effort than I ever imagined.
And you can go to the third slide.
The third slide it is.
Perfect. Okay, so before we get started, I would like to just see by a show of hands if you all feel comfortable sharing with a friend or knowing for yourself the effects of marijuana. So if you were to use marijuana, okay, a few of you. All right, great. And so for those of you who may not be as familiar, or maybe you're only familiar with like THC-based products, then today I want to share a few of the other products that you may see, and then different ways that these products are being used and potential benefits and risks. Next.
Oops.
Yep, perfect. Okay, so just kind of covering the basics. So when we think of marijuana, you know that marijuana comes from a plant, and so that plant is the cannabis plant. There are different strains of cannabis. So we have cannabis indica, we have cannabis sativa, there's also hybrids, there's other different forms of cannabis. However, these two are probably the most common that are being used and that you will see in dispensaries. So a lot of them will say this product was based off of, cannabis sativa plant or a cannabis indica plant. And then within these plants, you have what are known as cannabinoids. And so there's a ton of research being completed right now out there about how many different cannabinoids are in the cannabis plant. And so these cannabinoids are the different components in the cannabis plant that provide potential therapeutic benefit. And so the most common cannabinoids that you'll see, at dispensaries or that you may see around are THC, and then CBD, which is cannabidiol. And then there's a little more research and evidence coming out for CBN. I'm not going to focus as much on CBN today, just because there's still not a lot out there. And the most common cannabinoids that I've seen and that we have, risk versus benefit information on are THC and CBD. So we'll focus on those two today. One amazing thing is within your body, you have an endocannabinoid system. So if you'll move to the next slide. And within that endocannabinoid system, you have cannabinoid receptors. So you have CB1 and CB2 receptors. Has anyone heard of the endocannabinoid system? A few of you? Okay, great. And so the overall goal of this endocannabinoid system in our body is to maintain homeostasis. So just to maintain, normalcy in our body. And we maintain normalcy by, within our body, we have these endogenous cannabinoids that bind to these CB1 and CB2 receptors to just make our body act normal. One thing that I do want to point out, and one thing that's really important for me as a pharmacist when I talk to patients, is where the receptors are located. So if you look at the picture to the left, you can see that the CB1 receptors are primarily located in your brain. So they're located in your central nervous system where these receptors, if they're stimulated, they're really going to potentially affect a lot of our normal actions. So for instance, in your brain, that controls your appetite. Your brain also controls thoughts, it controls your balance, things like that. So it's important to know where these receptors are located. Now CB2 receptors, on the other hand, are more located like in your periphery. And so that's important. These two receptors are important so that when we talk about THC and CBD, we know where they're acting most in our body. Next slide. So the thought behind using marijuana or using THC is something called the endocannabinoid deficiency. So I've already described that you have this endocannabinoid system, and your body produces already these two endogenous cannabinoids, so AEA and 2-AG. However, if there's disruption with the production of these endogenous cannabinoids, or if there's a lack or a deficiency in these endogenous cannabinoids, then for instance, if you think of a disease state like migraines, the thought is that patients with migraines have a deficiency in these endogenous cannabinoids. And so what needs to happen is they need somehow to produce these cannabinoids so that they get over their migraines. And so THC is very similarly structured to our endogenous cannabinoids. So if you have this deficiency and replete it with THC, then that can provide benefits for some of these disease states that are affected by this endocannabinoid deficiency. I know that's a lot, but I hope I explained that fairly well. It's a pretty complex process, but when you think about, a deficiency and then being replaced by cannabinoids like THC or CBD, then it makes sense why these products may work. Next, please. Thank you. Okay, so now we're going to talk about the two different products. So like we already discussed a little bit, just in the pre-conversation, is CBD or cannabidiol. So this product, I really like to recommend this product for patients who are interested in trying marijuana. And the main reason why is because it doesn't have any psychoactive properties. So what I mean by psychoactive is you're not going to have the feelings of euphoria. You're not going to have, feelings of like out of body experiences. And when I'm talking to, an 85-year-old who wants to use a product, I'm trying to think of the safest product for that person. Another great thing about CBD is right now there are a lot of combination products that are coming out. And when you use a combination product like CBD and THC, when you use them together, CBD will actually decrease the psychoactive effects of THC. And I'm going to talk in a few more slides, like what I feel like is the perfect combination together in order to see those decreased effects. Another thing to keep in mind is that THC, it has a really high binding affinity to CB1 receptors. And so if you remember, those CB1 receptors are located primarily in your brain. So it completely makes sense why THC is, causing some of these more psychotropic or psychoactive properties. It does bind to CB2, but to a lesser extent. And then CBD doesn't really bind to the CB receptors unless it's at a pretty large quantity, just because THC is more of the has more active binding to those receptors. And then you can go to the next slide.
Oops.
So as a pharmacist, and I wanted to keep this in here, I didn't know if I would be talking to any, other people who are pharmacists or in the medical profession, but one thing that I have to think about with, any product is metabolism. So how is this product metabolized in our body? Because your metabolism changes throughout life, as I'm sure, we all are very aware of. I have to, watch what I eat now, and about 10 years ago didn't really have to worry about that. And so it's important to know about metabolism just so you know if effects are going to, last for a longer time or they're going to last for a shorter time. And so both of these products are extensively metabolized by your liver. And so these are just different enzymes in our liver that metabolizes THC and CBD. And so one important thing that you want to consider is if you are using a product, whether it's THC or CBD, and let's say you're taking a few other medications for, hypertension or for diabetes, for some condition, then those medications may be metabolized by the same enzymes in your liver. And so that means that your liver has to work a little bit harder, but it could also decrease effects of either the medication you're taking or the product that you're trying to use for pain. question.
Do you want to have questions asked now, or do you want people to reserve their questions for later?
Whatever the audience feels would be best.
Well, then I will ask a question. Please define well what metabolized means.
Yes. Okay. So what metabolized means? So for instance, with THC, so it's metabolized by cytochrome P450 enzyme. So there's this enzyme in your liver, and it is actually breaking down the THC, and spreading it throughout your body. But the biggest thing with metabolism, and specifically THC, is that when it's metabolized, THC then is metabolized, or it's changed and broken down into a very active metabolite in your body, so an even more active form. So like if you were to eat an edible that had THC in it, then the THC chemical goes through your liver to be metabolized, and what comes out is this really active metabolite that can oftentimes lead to, some of those side effects that we're talking about. Does that answer the question? So breaking down the medication.
Is there a system in the body that clears these active ingredients?
Yes. So a lot of times, different chemicals are cleared either like through your kidneys, so you may excrete them in your urine. Some, medications and like THC is actually stored in your like fat tissue. And then, excreted over time through like sweat. So a lot of the excretion is typically through the kidneys. Yeah. And next slide. Yep.
So the metabolized is what makes it active.
Yes.
It doesn't. You couldn't just put THC into your bloodstream and directly have the effect. It has to go through the liver and turn into something in order to
have
the effect.
So when it goes through the liver is typically whenever you're like taking a medication or a product orally. Now, when you directly inhale a product, so like you're smoking or vaporizing, and we'll talk about this in a minute, when you smoke or vaporize, it immediately goes into your bloodstream. Immediately. So it actually doesn't have to go through the liver. That's one thing about like inhaled products, and we call it bypasses first pass metabolism, and first pass metabolism is where it's metabolized in the liver. So that is only true. The liver is only true for specific like edible products, or if you ingest something.
But metabolism breaks it down, not makes it active.
It breaks it down, yes. But with the edible, so with edible THC, it actually does produce an even more active metabolite.
That's what I think he was. Yeah.
Oh, okay. Okay, sorry about that.
In my experience, when people would eat an edible and not feel anything, and they say, okay, I'll eat some more,
Right.
and not realizing that maybe it takes about 45 minutes
Yes.
or so to get it into your system.
That is correct. And I actually have a slide talking about the different products and like their time to onset, and then how long they can last. So how long those effects can last. So then another thing that I, briefly mentioned earlier is, worrying about medications that you're taking. So for instance, and these are studies that have been done specifically with THC-based products, so not CBD. But warfarin, how many people have heard of warfarin before? Coumadin, yeah. So, a very, very popular blood thinner that's been around forever, and, that a lot of patients may be on. And if you're on warfarin, you have to have a blood test, sometimes weekly, every 2 weeks. And what THC products can do to that blood test is there have been case reports saying that it can increase it or it can decrease it. So just knowing what to counsel a patient on if they are using a THC product and taking warfarin. So my big I received this question a lot, especially from pharmacists and healthcare providers, is, well, what do you say? Like, I have a lot of patients who use marijuana and they take warfarin, and my response is, well, I just tell them to be consistent with it, you know? So if they smoke every morning, then they need to, you know, smoke every morning and let us know if there's a change so that we can know how to adjust the medication. CNS depressants, so like alcohol, benzodiazepines, medications that already depress or cause some of those, you know, more sedating side effects, more of the what we would call, you know, side effects for more like relaxation. You probably don't want to take those in combination with THC because it's a lot of the same side effects that you're already experiencing. And we can go to the next slide. And then this is just another chart that a study looked at, you know, the two different cannabinoids, THC and CBD, and you can really see how in a lot of these effects, you know, they're kind of opposite of each other. So, for instance, CBD is used a lot of times in pediatric epilepsy, so like a seizure disorder, because it has anticonvulsant properties. Another great benefit of CBD is that you can potentially use it to reduce your anxiety. One thing that's not listed up here is it has anti-inflammatory properties. So that's why it's a good cannabinoid to use for pain or for inflammation that you may be having. Some of the things you want to look out for with THC, we can move to the next slide, are going to be side effects, cardiovascular side effects. And so, you know, there are a lot of people in the United States who have cardiovascular disease, and studies have shown that if you use a lot of THC, then it can actually increase your heart rate. There's a disease state called atrial fibrillation that if you have, you know, that specific disease, you probably don't want to use a THC-based product because it could make your heart go out of rhythm. And so that's just something, you know, to think about with THC-based products. Other things specifically, if you're smoking rather than vaporizing, you could have increased sputum production, just because when you smoke, it goes through the process of combustion, and so it releases those chemicals into your lungs, whereas vaporizing, it's not heated quite as high, and so it doesn't go through that combustion, and it may be a little bit safer than smoking. And then we've already mentioned some of the brain side effects, or what we call our CNS side effects that can happen acutely if you use a THC-based product. And then there's not a ton, just because, you know, there hasn't been a lot of research out there, but one thing that I like to know is, what are the long-term effects? You know, are we going to see an increase in Alzheimer's disease, or, you know, what's going to happen? Because we know that THC specifically is very centrally acting, so it's in our brain, and our brain controls a lot of our body. So what is our use of THC like doing long term to our body? There are a few things that it could potentially reduce your bone mineral density or your bone strength. For men, it can decrease testosterone. And then other things, we do know that it can impair memory, but you know, there haven't been any confirmations that it, you know, leads to dementia or leads to Alzheimer's. Next, please. Okay, and then some of this I've already mentioned, but you know, for situations where we absolutely would not want to use specifically a THC-based product would be someone who has acute psychosis, and that's just because people think that THC actually relaxes you, but it really does the opposite. It actually has been known to cause psychosis in patients, or even increase anxiety in patients. So that's just kind of one of the big disclaimers. If you do have, an unstable mental condition or a history of psychosis, then it may be best to try a CBD-based product, which could potentially help with anxiety. Next, please.
Question?
Yes.
It says there that it may have renal impairment.
Oh, so yes. So it says it may have renal impairment and hepatic impairment, which means kidney and liver. And specifically, a lot of the, new chemicals or drugs that are out there that we don't know a lot about, if it hasn't been studied in patients with like renal or kidney impairment or liver impairment, then they always just caution use. So that's more of a, we're not sure exactly what it may do. It could prolong the effects, just based on it being metabolized through and broken down through the liver. It may prolong those effects, but we're still just not sure about it. Yes. Next slide, please. All right, so now we're talking about the different formulations. Oh, I think maybe one slide before this. Sorry. So the first formulation we'll talk about are our different inhaled formulations. And so when I say inhaled, I mean the vaporized formulations and then, smoking. And with these formulations, one good thing about them is they have immediate onset. So let's, in my study where we looked at patients who had migraine headaches, those patients, as soon as a migraine came on, they wanted something that worked immediately. And so a lot of them would smoke or vaporize a product, and then they said that completely made the headache disappear. And so that's because, it just immediately acts. It goes straight into your blood system, straight to the brain. And if you think about that endocannabinoid system, it's really fulfilling those receptors that are deficient. The effects can last up to 2 hours. And then when you're thinking of dosing, since effects last every 2 hours, and let's say that you vaporize, you don't really feel anything, you should have an immediate onset, then it's easier to know, okay, maybe I need a little higher of a dose. And then like I mentioned earlier, we prefer vaporizing over smoking, just clearly because of that combustion. We don't want all of those chemicals to go straight to our lungs and cause bad products to just sit in there. Next slide, please. So then next we have our oral formulations, or our edible products that we think of. And so like a comment was made earlier, edible products, really, it's very patient specific. And so this is one thing that I caution. I feel like edibles are kind of the new rave. The patients that I work with, they don't really like the idea of smoking, whether it's, vaporizing or smoking. And so they want to try an edible. And they have, gummies, they have everything out there. And so the biggest thing is, it can work, as quick as like 30 to 60 minutes, or it could take up to 2 to 4 hours before you actually feel an effect from an edible. And then those effects can last up to, reports have been up to 8 hours. And so, again, going back to the study that I talked about with migraine headaches, if you have a migraine, you don't want to wait 4 hours, with an edible. And so a lot of the patients in this study, they would use an edible to actually try to prevent migraines from occurring. So they would take an edible, at night before they went to bed to hopefully prevent waking up with a migraine in the morning. Another piece of advice that I have is to start low, just because you don't know how the effects are going to, act on you. And so I'll talk about dosing, I think, in 2 more slides. Another thing is you can redose after, I usually tell my patients after 2 hours, but for younger patients, you could potentially try to redose an edible after about 90 minutes if you don't have, if you haven't experienced an effect. And so that's just something, I know some of the products out there now, they actually tell you when to redose. Before they didn't. And so we had, we saw a number of cases of emergency department visits of people who would try it, would wait like 10 minutes, I don't feel anything, try another one, and then all of a sudden they have this, effect, overdose basically. So.
I apologize. I'm having a little difficulty with
No,
my
you're fine.
mouse, of all things.
You mentioned overdose.
Yes.
Has anybody overdosed on THC and
Right,
had
so-
severe complications?
So no one has actually, overdosed and died specifically due to marijuana or THC, but it's more of like overdose type symptoms. So, like a really fast heart rate and sweaty. But yeah, that's a great clarifying point. Okay. All right. So I think the last thing that I did want to talk about before I move to this is topical agents. So topical agents would be like the creams, the lotions, the oils, the patches. And one thing, I'm glad that before this we talked about, even using topical agents for dogs. I think CBD oil was honestly used on dogs before we started experimenting with it. And so, if it's safe for your pup, then it must be safe for you, right? Topical agents are, that's my primary first line agent that I'll recommend for patients. Onset is anywhere from like 15 to 45 minutes with the topical agents, and they can last up to 2 hours. But you have to apply it a lot. So it's really good for like arthritis pain. Even I have patients who use it for low back pain, and they find it really effective, but they state that they really do have to apply, quite a bit of these topical agents to cover the pain. Yes.
When you say quite a lot, do you mean a lot of the actual salve or oil or whatever, or do you mean a lot of times?
So it's actually both. So unfortunately, like if they're using a cream, they state that they really have to, like apply. So they'll rub a cream on and then even do like a second application, and then apply it again like 3 hours later. And unfortunately, those products are costly. They're pretty expensive if you're applying them that frequently. But one thing that patients do is if they know that they're going to be out and about, like shopping for a half a day, then they'll apply it before they go shopping and then take it with them and apply it again, and then, just use it whenever they're being active, whenever they may have like a flare in those symptoms. And so I think, yes, the next slide is what we were talking about, using the two, THC and CBD in combination. So we already know that THC activates the CB1 and CB2 receptors, and what I typically recommend for a starting dose of a THC-based product is 2.5 to 5 milligrams, and that's for someone who's never used THC before. Now, if you use THC, let's say in the past, like 20, 30 years ago, I would still recommend this same starting dose because the stuff that's on the market now is really, really potent. And I had, a patient that I was working with, and she said, I smoked marijuana like in the 70s and 80s, and I went and got this THC product, this gummy product for my pain, and I only took one of them, and she then went to a massage therapy appointment, and she had a terrible reaction. She actually had to leave her appointment. Her husband had to come pick her up. They had to call the ambulance as well. And, and she said, that stuff is just so strong. So she actually followed the recommended, it's packaged typically in 10 milligram doses. So I even go lower than that. I say take a half half of, you know, what is really out there, just to see how it affects your body. And then specifically for CBD, so, you know, this is the one that we're going to use for pain and for inflammation. Studies have tried doses up to 800 milligrams without any, you know, really bad side effects. And so CBD is one of those that if you use it over time, you can become tolerant to it. So you need to, you know, potentially increase your dose over time. But you could still start at a 5 or 10 milligram dose and then continue to increase that if needed. Depending on the formulation that you're using, you may want to dose CBD a few times a day. Like if it's a CBD-based edible product, you could potentially dose that like 2 to 3 times a day. But I've really had great success with patients who have had pain, who have used CBD-based products. And then I would say kind of the next exciting thing or product that has come out is this combination of CBD and THC. So before, there were a lot of like 1-to-1 ratios. However, if you have that 1-to-1 ratio, and what I mean by that is you have 10 milligrams of CBD and 10 milligrams of THC, so that's a 1-to-1 ratio. You can still get some of those THC side effects. It is very patient specific. Some patients may not experience as much of the euphoria and the psychotropic effects of THC. However, what I have found is if you use a higher CBD component, so a 10 milligram to like 1 milligram of THC, patients have not had any like euphoria or any of the negative effects of THC. And so I feel comfortable when I'm talking to a patient, you know, who really wants to use a marijuana product for whatever they're going through. I feel comfortable suggesting a 10-to-1 product for them. And, you know, if I'm a little worried, like if they're a little more older or, you know, they're at an increased risk of falls, then I may tell them just to like cut that product in half, because a lot of these products are in the edible form. And then, you know, just try that. I also recommend a diary. So, you know, record what time you take it, record your effects. But I have found success in that higher 10-to-1 ratio combination. Next slide, please. Oh, okay. So we already talked about the topicals. Yeah, so we'll go.
I have a question on topicals.
Yes.
Are there any psychoactive effects from topicals?
So this patch that's up here, the Mary's Medicinal patch, so that is just a THC-based patch. And, you know, typically when you think of topicals, they're very localized, but with this patch, there are reports of, you know, not as strong of the psychotropic properties, but yes, there is some what we would call like full body absorption with the patch.
So
that's
patches,
THC.
but not like transdermal, like salves or things like that.
Yeah, I haven't heard of any reports with the transdermal like salves. A lot of them do have the CBD mixed in with them, which is absorbed a lot better in the skin than the THC is. Question.
I have a friend who was a trimmer, and that's a regular trimmer in the marijuana grow industry. That's a regular job. You minimum wage. You go and you spend all your time trimming the plants to make them look good and getting rid of the stuff that's not good. And he reported that he got a full high. He had to kind of be careful just from doing the trimming. So it does come through your skin and does get you active, at least from that one person's report.
Maybe you should wear gloves?
Yeah. Yeah, he would wear gloves.
Well, in terms of like, you know, recommending it for older folks who are fall risks, you know, it's not the equivalent of smoking or having an edible to do something transdermal.
Right, that's correct. So a lot of times I'll actually recommend like the creams or the ointments. If it's more, if it's something more localized, it depends on what it is. I've worked with spouses who are caring for, their spouse who has dementia with agitation. And so specifically, for something that is like dementia with agitation, then I wouldn't recommend a topical for that. And so usually we'll recommend more edibles just because, they're full body effects. So topicals, when I think of topicals, it's more for like localized pain or arthritis, or it's really great for low back pain, things like that. Yeah. So now we're going to switch gears and just talk about some of the evidence that's out there. So some of the disease states that have evidence specific to older adults. Yes.
Are the patch topicals good for local pain? Like if you have shoulder pain?
Yes. So they are. We have patients who will use like a patch, for lower back pain or for like shoulder pain. I would just do more of a CBD based product, not the straight THC based products for that. And then we can go to the next slide.
Can I ask you a question then?
Yes.
Specifically related to pain.
Yes.
It's my understanding that that the products help you manage pain. You basically feel better. Not that your pain has gone away. The pain is there.
Right.
Right. This does not cure pain.
It doesn't. No, I would say it doesn't. Yes. So you're not
Okay.
just going to use it once and then never have to use it again. Yes. So all of these products and the disease states would be more for management. So like for instance,
Like aspirin.
yeah. Yep, or just like, unfortunately, we're in an opioid crisis where people are using opioids for pain, for chronic pain, and even that opioid is just to help them manage pain. So it depends. It can definitely reduce your pain, and so we actually are talking, the first one we're talking about is chronic pain, and what they found with marijuana-based products on chronic pain. Yeah, so yes, it manages, it does not completely, it's not the end-all be-all.
Next slide.
Yes, please.
Sorry.
No, you're fine. Okay, so so I think the next slide is talking about chronic pain, but these are just some of the the big medical organizations and kind of their statements right now on marijuana. And so the American Academy of Neurology, so this is probably the biggest, so neurology, when we think of neurology, it's a lot of things that happen in our brain, and this is probably where we have the most research. But they actually do, support the use of oral cannabis, but they do say, there are specific disease states that we don't recommend it in. And so they're kind of one of the first, medical the first medical statements that say, hey, we do support the use of cannabis. The American Cancer Society, they also support research. They didn't specifically come out and say, oh, we support cannabis use, but they do support more research. And so I think we're going to see a trend towards a lot of these different medical groups and organizations saying, hey, we need more research, we need more evidence, and I have patients who are telling me it works, but there's nothing changing with our federal laws, and so that I can actually discuss this with my patients or use that. Next slide, please. Currently we have 2 cannabis-based medications that are approved in the United States. So dronabinol or Marinol is FDA approved. It's a synthetic THC, so it's a chemical that is like THC, is what that means. And then nabilone is also another synthetic THC. That's a tablet form as well. One of the new ones that is currently going through what we like to call our phase 3 studies, so this is like the last phase of studies before it will potentially be approved by the FDA, is Sativex. And this is actually a spray that patients would use. And if you notice, it's a CBD THC combo. So we're moving in the right direction. Granted, it is, a 1-to-1 combo, but I think even researchers are starting to realize that this combination can be beneficial for patients. It's already approved in Europe, and so, they use it for all different. They use it for pain. They use it for a lot of neurological disorders, and so I think we'll see it come to market pretty shortly. Next slide, please.
Is that
Next
synthetic,
slide.
that last one, Sativex, or did they?
It is
it's natural?
not. Yeah, it's actual. Yep. And the next slide, sorry.
It's not a problem. These are the only
It's
FDA.
not-
Oh, yeah, no, the next one. This is just kind of my little, we're going to review the evidence now.
But they're synthetic.
Okay, so first we're going to talk about chronic pain. This is the most data that we have for use of marijuana. And as you know, California recently approved recreational use of marijuana. And so they looked at adults who are 60 years and older who are using medical marijuana, and they sent a survey out to these adults. And so as we know, when we get a survey like via mail, the response isn't very great. But of the patients who did respond, if you look, you can see that 97% of them reported a decrease in opioid use, which is huge. We're in this big opioid epidemic, and so these are patients who are using cannabis, and they've reported this decreased opioid use. So basically what this study showed, if you look at some of the other comments, patients seemed to like using cannabis and thought that cannabis worked better for their pain than opioids. They wanted didn't want, but they felt like the side effects were better than opioids. And so I think this is, a really big turning point. And my clinic partner is with the Colorado Opioid Consortium. So for the state of Colorado, she's on that working group, and that's kind of been the big question that people are asking is marijuana the answer? Is this going to help us get out of this opioid crisis? Or, 15 years down the road, are we going to be in a marijuana crisis? And so I think, again, more research is what we really need. Next slide, please. So then there was specifically a study in adults who were 65 and older. There aren't a lot of those studies out there when you're specifically looking at marijuana. So if I find one, I get really excited. And it had quite a few patients. So it almost had 3,000 patients. Average age was 75 years. So these were, older adults with over half of them using different types of cannabis for pain. And so you can see the reported types. They were using oils, they were smoking, and they were vaporizing. They followed these patients. So these patients previously they had not used cannabis. And so they followed them, and they checked in with them at 1 month and at 6 months. Next slide, please. And what they found in these patients is that so if you think of pain, oftentimes we ask, what's your pain score, on a scale of 0 to 10. So at the start of the study, before using cannabis, patients reported a pain score of 8. So that's very high on the scale of 0 to 10, or 1 to 10. And then at 6 months, they reported a score of 4. So it really decreased their pain. And one thing that I like to talk to patients who have pain and who are using any medication for pain, I tell them, I'm probably not going to stop your pain, but I at least will help you get to a pain level where you can do activities that you enjoy. And so I think a level of 4 is, a pain score where I think a lot of these patients could actually enjoy activities and have a good quality of life. There were reports of side effects, so dry mouth and dizziness, side effects that we would expect from, specifically from smoking or more THC-based cannabis products. And then the most shocking finding for me, as a pharmacist and working with older adults, was the decreased fall rate. So if you look, before the study started, patients reported 1 or more falls in 6 months prior. So almost 300 patients reported a fall. And then after 6 months, so they had used cannabis for 6 months, only 113 patients reported any fall. So if you're thinking, that THC can cause like dizziness and, euphoria, I honestly thought that the fall risk was going to be increased. But the more I started thinking about it and, wondering why was this decreased, I think it was because their pain was better, and so they were actually able to get out and move around and maybe go to physical therapy or maybe do yoga or maybe do something to help build their strength, and maybe that's the reason that the fall rate was low. But I thought that was very very, very powerful question.
So in this study you said that some of them used oil. So does that mean edibles or does that mean oil on the skin?
Oh yes, that's great. So they were using edibles. Yeah, it was like cooking oil.
Cooking oil?
Yes, so like in an edible form.
I see. Okay, good.
Yes.
That's how you do brownies.
Yes.
When you make brownies,
Yeah, I know how to
you
make
Next
get
slide, please.
you get it into the oil.
Butter.
Before we go on to the next slide,
Yes.
how much more do you have? Because
Oh, yeah,
I need to
timing.
take a break to.
I think I only have, I want to say after this, maybe 5 or 6 more slides.
Okay, so we're going to take a break for 30 seconds, for half a minute or so. So for technical reasons having to do with file sizes.
Can I ask a question? To look way back to endogenous cannabinoids, you said that there are some people that just have naturally low levels. And what are the symptoms of that? How would somebody know if they have naturally low levels?
Yeah, so unfortunately there really isn't a way to know unless, they're thinking that it could be one way that you may know is if you have, an autoimmune disorder, maybe that's somehow linked to the endocannabinoid system, or if you have, they think that irritable bowel syndrome is another potential cause of a deficiency in the endocannabinoid system, but there's no way that I'm aware of that you can actually check, or that you would have any symptoms other than seeing if cannabis helped a medical condition that you have.
Well, you mentioned they're mostly autoimmune kind of things.
So migraines isn't autoimmune, but irritable bowel syndrome, yes, and then there have been other rare autoimmune that have.
And arthritis is arthritis,
rheumatoid arthritis. Yeah.
Okay, can we stop for just 30 seconds, please?
Yep.
Oh, I thought.
Okay, so we can go to the next slide,
We want Ralph
please.
to have the first installment of 60,000.
I'm teasing.
We know.
And then I know this slide is a little bit difficult to see, but just something that I've already alluded to. This was reported in 2016, and basically the whole gist of it is that they were able to look at national fills for prescriptions, so prescription, refills and just prescriptions that were written for these specific disease states. And the one that I want to point out is pain. And so you can see a decrease in the number of prescriptions written for pain. And they compared that to states that had marijuana laws and then states that didn't. And so this decrease is for states that have marijuana laws. And so you can see a drastic decrease in written prescriptions for, like opioids or just medications for pain.
I just saw Christy take a picture of this slide. Will you be providing this
PDF. Mm-hmm.
As a PDF?
As a PDF, yep.
Provide this for a PDF, and if you want to get a copy of this PDF, contact me and I will forward it on to you.
And on the bottom of all the slides, I have their references too, so like you could easily copy and paste. Like if there's a study that you want to, know more about, feel free to, find those references on Google.
You had a slide up about a study. Was that a double-blind study?
So it was a randomized study, yes. I don't think it was double-blinded though.
Yeah, it's basically the same.
Okay, the next is spasticity related to multiple sclerosis. And so, these are just side effects if you have more advanced multiple sclerosis. And you can see they used all different types of THC products. And they all of the studies were placebo-controlled. So they compared cannabis to placebo. Next study. Or slide. And so what they found is that there was an improvement in the spasticity. And so patients reported decrease of these, side effects related to multiple sclerosis. But the one thing that they didn't find was any difference between the different cannabinoids that were used. So, it showed dronabinol and some of the other, like, THC combinations. And so it potentially, could be useful, but they're just not sure which product would be best for, patients with multiple sclerosis. Next slide. And then Alzheimer's disease. So that's kind of the question. Does it cause Alzheimer's disease? Well, actually, we have, quite a few patients with Alzheimer's that are using cannabis, and mostly for, agitation-related symptoms. So these are 3 different studies. You can see the number of patients is a lot smaller. So only about 100 patients out there that we have evidence for that have used cannabis for Alzheimer's disease. And 2 of the studies were positive. It showed, that it did really reduce agitation. It reduces a caregiver's burden. So it allows them, to do laundry, to wash dishes, to be able to do, chores around the house. But when they specifically looked at just THC in tablet form, they didn't really find a difference in agitation. And so I think one thing, just thinking about the 2 cannabinoids, I think a product, with more of the CBD might be the answer for Alzheimer's with agitation. Next slide. Insomnia. So there have been a few trials that have looked at insomnia, not really, again, in the older adult, but the mean age was 50 years for patients, and they actually compared it to a medication that we can use for insomnia called amitriptyline. And so they specifically looked at nabilone, which is that synthetic THC. And what they looked at was just the quality of sleep that the patient had. And they found that overall patients had improved sleep with nabilone compared to this other medication that can be used for sleep. But they also found that side effects were more common with nabilone. And so that's that synthetic THC. And it's a lot of the side effects that we would expect from THC. So dizziness, dry mouth, some nausea. Yes?
How is THC used for insomnia when it wears off so quickly?
Yeah, so this was with the oral product, and so that one, so if you think of, edibles, they can last up to like 6 to 8 hours. And so that's kind of ideal for a lot of our sleep medications that we want to use. We want, we don't want something that lasts like 12 hours because then it could impact you the next day. So these were specifically the oral products. Yeah. Next slide, please.
Mouse.
The
No, it's
approval was
fine.
given by the FDA to the synthetic THC.
Synthetic
Is
THC,
it-
yes. And that's
Did they
because
approve
it's,
synthetic because they can control?
they can control the chemical, yeah. So it's a chemical like THC. Yes. And so then the last disease state that we're going to talk about,
Still trying.
no, you're fine,
Okay.
is glaucoma. Probably where we have some of the least amount of evidence. 18 patients in this study, and they looked at a THC cigarette versus like placebo THC cigarette, and they wanted to see if it decreased intraocular pressure. So this is, a disease state that you worry about when you get older. So they wanted to see, hey, could we kind of reverse it by using THC? And unfortunately, overall, the answer is no. It works for about 90 minutes, so for about the amount of time that THC is active after smoking, but then after that, your intraocular pressure, which is what you measure for glaucoma, goes back to baseline. So not really the agent. A smoking or a vaporized or smoked agent isn't one that we would want to use for glaucoma. Next slide. And this is just kind of a big chart of all the studies. This was a big review article that came out in JAMA, so one of the big journals that is out there, and it looked at all of these different disease states. Today I focused more on disease states that are seen in older adults, and so you can see on the very far right is what we like to look at. It's called the grade of evidence. So is this like really high grade evidence? Is this, what we want to change guidelines based off of? And so as you can see, we have some moderate grade evidence, which I think is great to have just with cannabis in general, considering that, they're really limiting the amount of research that we can do. But for the most part, a lot of the other evidence that we have is low grade evidence. And that's mostly due to a small number of patients and, not being placebo controlled or not having like a standardized product for those studies. And so the next to last column is kind of what I like to say in terms of like the benefits of cannabis in those studies. So 2 thumbs, it seemed that cannabis was beneficial for pain and then for spasticity. And then you can see further on down, there's some where we probably don't want to use cannabis products just because we don't have the evidence and we need a little more information.
So there was very low evidence for depression.
Yes, so there was no direct study. They pulled that data from studies who did like a depression assessment, but they didn't specifically look at depression. So like there's a lot of different tests out there that you can screen for depression, and so studies included that, but it was like, for instance, like the anxiety study, and then they would do like a depression scale on that or a depression test on that study.
Depression and anxiety are very hard to define objectively.
Mm-hmm.
Very hard to study.
Yeah. Yeah.
It's very PTSD is something that the marijuana helps with.
Mm-hmm. Yes.
And again, just managing that anxiety a little bit. And
yeah. No, definitely.
Mm-hmm.
Next slide, please. So I think I've mentioned some of this, but for me, as a healthcare provider, I really try to be open and ask patients questions and try not to create this stigma that unfortunately I think is still around within the healthcare system related to marijuana. And so just kind of some of the things that I talk about are side effects to experience and then the response to experience as well. And I would be more than happy afterwards to receive any comments of how you feel as like me as a healthcare provider, how, you know, I could be open or even pass along to the providers I work with just how to create more of an open environment for patients. Next slide, please. Other important notes is related to driving. So these are specifically Colorado rules related to driving based on research that they've done. So if you use a smoked or vaporized product, try to avoid driving 3 to 4 hours after, and then 6 hours after an oral product. And then we do have intoxicated level of THC for the state of Colorado. And then this is my last slide, so this will be included too. A lot of these different websites have like some of the upcoming research that's being done. It has information for, you know, you as a patient who may be interested. And so it just, I think these websites are really good just to help learn more and to provide you with tips and tools to be able to, you know, answer questions and feel safe about using marijuana. And so with that, I'll take questions.
Okay, we have, okay, I knew this was going to happen.
It's okay, Christy's
Okay.
on top. You're first.
So we have Kate, who else? Scott,
Christy.
who else?
Christy was the
Christy.
first one with her hand up.
Blake,
On my eye.
Blake, anybody else? And Ralph, because I have 6 questions I've written down. And Deidre. Yeah, you know, her hand went up too late. Okay, so Kate, you're up.
What's the difference between CBD from marijuana and CBD from hemp?
Great question. So I usually start, my first slide usually is the difference between like marijuana and then hemp. So they're both from the cannabis plant. Marijuana that contains, like, so I like to call hemp the plant and then marijuana the plant, because in Colorado we use a lot of the marijuana, or of our cannabinoids are from like marijuana. Hemp is the male form of cannabis. So, you know, plants and flowers, they have like the female and the male form. Hemp is the male form, marijuana is the female form. Hemp contains a higher CBD component. Very, very little THC is contained in hemp, whereas marijuana contains a much higher THC component, and you really have to work hard to extract that CBD. I will say hemp farms are becoming very popular in the U.S. I think right now Kentucky is like the leading state for hemp farms.
The people that were against X, our latest thing, said that Colorado was a leading hemp provider.
Oh, okay.
So that I saw that in my little
Okay.
look at the propositions thing. So I don't know if it's true or not.
Yeah.
Somebody claims it.
Yeah. So so that's the biggest difference, is actually the amount of like CBD and THC each of them have.
Scott, you're up. And please speak loudly.
As a physician and as a libertarian, I'm very much in favor of legalization or legalized marijuana. But I strongly object to the use of the term medicinal marijuana, which you avoided rather well, I thought. Medicinal marijuana is kind of like medicinal wine. It's an excuse to try to get around prohibition. If you're really going to treat it as you are pharmacologically, cannabis would be a much better word to use than marijuana, but the best ones would be the actual substances, CBD and THC.
Yeah.
I really think it's very poor to use the term medicinal marijuana, but
Yeah.
I thought you did a good job of
Thank you.
explaining the actual pharmacy and the drugs.
Yes.
I also agree that the research has been held up and needs to catch up to it.
Yeah, thank you for that comment. No, over the years, I've really tried to steer away from saying, medicinal or medical marijuana, just because a lot of the products that you would see in a medical marijuana dispensary versus a regular, they're the same. They're just it's a little bit cheaper at a medical marijuana dispensary.
We have Christy.
So if you would...
Please speak up, or get the microphone closer to you.
Okay. If you were going to recommend somebody replace a sleeping pill with something like an edible, what sort of dosage would you recommend they start with?
Yeah, so again, I would recommend that 10-to-1 ratio of the edible. And there actually are brands out there that have like 10 milligrams of CBD and 1 milligram of THC. And so usually I just say try one gummy.
Uh-huh.
A lot of them are gummies. They do have some capsule formulations out there too.
And I know that if you take sleeping pills long term, they have terrible side effects, but I don't know what they are off the top of my head. But can you speak to that? You know, like how it would differ between the THC or CBD edible versus the sleeping pills?
Yes. So the question was about sleeping pills. They have long-term side effects, and so some of the long-term side effects, that I'm worried about as a pharmacist are memory impairment. A lot of our patients who are on sleeping medications, do things in the middle of the night that they're not aware of, like cook dinner or go drive their car. Or we had one patient who went outside, in their lawn and tried to mow the grass, like just, all these things that can happen that they're not aware of. It increases your risk of falling, because if you're taking this, sedative medication before bed and you have to get up in the middle of the night and go to the bathroom, then you're at an increased risk of, falling. Or did you have a comment too?
Yeah, I was going to add to that.
Yeah.
Sleeping medication is a big difference between those that help you go to sleep and then those that help you stay asleep or go back to sleep if you have to get up, like you just mentioned. And so you'd be wanting to look at which one is that you're trying to do.
Yeah.
But that's a very good point, is that if it lasts too long, it starts to cause other adverse side effects.
Right. I just know that there's some older people in my life who can't sleep without a sleeping pill.
Yeah.
And I would like to be able to say to them, hey, maybe you could, lose some of the bad side effects by having an edible instead.
I, for example, use a non-prescription sleep medication that doesn't help you go to sleep. It helps you go back to sleep. I have to get up to wake up. And so far, I haven't had any side effects from that. So probably another good point is to try different things and see what seems to work best before you these side effects.
And we so actually right now we're in the process of trying to help patients who are using some of these sleep medications. So it's a new project that we have in our clinic, come off of these sleep medications. And it's not, depending on the medication, like if you're on one of those that's longer acting, it's not good to stop that medication cold turkey, because you could have, very bad withdrawal side effects from stopping cold turkey, depending on the medication that it is. But usually I try to recommend more non-medication related items before I recommend a medication for sleep. So like cognitive behavioral therapy works really well. You'll be amazed by how many people have bad habits before, like right before they go to sleep, and if they just change some of those habits, really helps them fall asleep or potentially have more of a restful sleep.
Blake, you're next, and speak up.
I have multiple questions, but I'll limit it to two.
Okay.
So, first of all, the FDA approved medications. If you take those in a state where marijuana currently is legal, and you move to a state where it's not legal, even for medical uses, do you have to quit taking it? The second question is, any studies relating to diabetes and marijuana and the effects?
Okay, yeah. So if you are using marijuana and you move to a state that does not allow marijuana, then yes, I would highly recommend you not use that medication or that marijuana product, just because you never know if someone may do like a urine tox screen and you're still using that, or if you had it, you know, in your car because you were traveling and you got pulled over, you would have to deal with the consequences of that. So I would, you know, highly recommend. I've had patients who, you know, have like traveled to Nebraska to visit family and then they got arrested because they had these products in their car. So I highly recommend not taking it into a state that doesn't allow marijuana.
Quick follow-up on that.
Yeah.
CBD, is that legal anywhere or everywhere?
So CBD oil. So there are like hemp CBD oils that people use all over the U.S. that, you know, they order online or, and so I haven't heard about any issues with, you know, hemp CBD oil. And she may know, Laurel may know better.
It's legal across the country and in other countries as well.
Yeah. So, and then in terms of diabetes, so that's a disease state that we also work with a lot in our clinic, and I haven't seen any studies right now related to diabetes and the use of marijuana. So that is one that, you know, I haven't seen studied, but maybe it will be in the pipeline.
It's like volunteer.
Yeah.
I'm next, and I'll ask one question and then defer to other people. Have the laws changed in terms of marijuana research?
So there is research that is able to be done. Like there are grants out there that are able or that allow for marijuana research. For instance, like both Children's Hospital and University of Colorado, where I work, hospital, they do have research for marijuana. However, they have their products that are specifically flown in from, I want to say I always get it confused if it's from the state of Alabama or Mississippi, but it's actually where they have a controlled environment for like cannabis products. And so they specifically use cannabis from this facility and use it in the studies. But in terms of like, you know, the huge, so I would say they've allowed more funding to occur with marijuana research than in the past.
Are these, just to follow up and then Deidre's next, are these NIH, National Institute of Health grants, or is it a different kind of grant?
So from my understanding, it's a different kind of grant.
Do
Yes.
you know what kind of grant it is?
No, I could send the link to the website over that has like right now the ongoing research related to marijuana, but off the top of my head, I do not know.
Deidre, you're up.
Okay. So I was just wondering, if you don't consider euphoria a negative side effect, what would be the CBD-THC combination that the ratio that you would be looking for if you want the benefits?
So probably that 1-to-1 ratio.
Okay.
Yeah. Yeah. And yeah. As a right. As a geriatric pharmacist, I have to worry about that a lot with my patients. But that's a great question. I'm glad you brought it up.
Bill, can I ask you to lean forward so
No,
when you
sure,
ask your question?
Well, it's not that you mentioned that we've got THC and CBD, and that CBN was coming on, and that there's like 17 compounds in the cannabinoids. And I think that's part of the difference between the American medical view of let's go and bring it down to just one compound at a time versus the left-wing hippie holistic view of you get the whole plant and there's lots of stuff in it, and it's going to be a hard time to get each of them isolated.
Right.
So CBN's the next one in line. Can you say a little bit about that? And do you know of any of the others that are coming in?
Yeah, so, I haven't done a lot of research on CBN. I think from, just from what I've seen, I think it is like pretty naive or pretty comparable in terms of side effects to CBD. So I don't think, I think THC is kind of the big guns, the more potent one that has, a range of different side effects. And in terms of other ones that are coming along, I'm not sure what other ones are coming along. But I think, just to kind of back up some of the medical positions, I think that one of the reasons why they're trying to, target like one or two to see the effects, I think it's more to try to determine what these long-term effects are, just so, rather than saying, okay, let's use this whole plant and then realize we have, a large number of patients using the whole plant and then trying to determine, well, how did this one, how did their arm fall off and how did this one get gangrene? Like what component is causing, these side effects?
It makes science very difficult if you have a lot of variables. So.
Yeah.
Anybody else before I ask my multitude of questions? Jerry, and yell or get the microphone right in front of Jerry.
What happens to our chances of being nominated for the Supreme Court?
First you have to be a lawyer.
No, you don't.
You don't have to.
No, there's nothing in the Constitution that says you have to be a lawyer to be on the Supreme Court. That is an aside. Okay, anybody else wish to ask a question? Go ahead.
Yeah, I just thought of one. We have some pills that I got from my mother to help her sleep. She's 100 years old and had Alzheimer's and agitated and all that. But I was tempted to take them myself, but I never did. So you've been sitting on the shelf for a while. What's the shelf life of pill? I don't know what they are.
Yeah, so usually I don't recommend taking a pill a year after it's been filled at the pharmacy. So the bottle should have a fill date on it. Like it should say October, 1st, 2018. And then I don't recommend it a year after.
Anybody else? Okay, then Ralph goes through his questions. Why does THC help with migraines? Do we have a clue as to what's happening there?
Yeah, so
I didn't hear his question.
so the question is, why does THC help with migraines? So part of it would be fulfillment of that endocannabinoid deficiency, but even more specifically within the endocannabinoid system, it is involved in your neurotransmitters. So like when you think of neurotransmitters, you think of like serotonin and dopamine and, all of those chemicals that fire and release in your brain for you to have emotions or feelings or everything that goes on. And with migraines specifically, they're not sure the exact mechanism, but there is potentially issues with the neurotransmitter serotonin. And so they believe that THC somehow, interacts, either, increases serotonin, but it mostly is involved with serotonin, and so THC is what stimulates and provides serotonin to the brain.
Not all migraines are the same either.
Right, that's very true.
So the short answer, I believe, would be we don't know.
Right.
Okay.
There's hypothesis.
All right. Is there an antidote to marijuana overdose?
The question was an antidote to marijuana overdose. That's a good thought. Potentially CBD, just because it would, bind to those receptors. The only thing that I could think of is just a ton of fluids. So just, like hooking up an IV and just flushing out the THC, because, there are theories out there that if you don't want to test positive for a drug test, then you drink, gallons of water before the drug test, and it is, excreted out of your body. But yeah, so I would say fluids, but no specific antidote.
Leads me to my next question.
Mm-hmm.
You sounded unsure of that last answer, okay, about using fluids. So my next question is, as a scientist, as a professor of pharmacology, how certain are you about your recommendations?
Which recommendations?
In general.
In general.
In other words, there's a huge lack of research out there. Okay, so I'm guessing that you are speculating, for the most part, about the recommendations that you're making.
Yes.
I don't know if that's true. I don't know if my assessment of your assessment is correct, and I'd like to get your assessment of your assessment.
Yeah. So, no, that's a great question. And I think, for instance, the study specifically on migraines, I would say that it was beneficial. I mean, it was, when you look at research, it was statistically significant in the reduction of migraines. So cannabis as a product was beneficial in patients who had migraine headaches. The one thing that we don't know is, what's the dose? How often should patients use this? For other recommendations, so I work with a lot of patients in our clinic who use marijuana for, all different disease states, and I feel confident in providing them the knowledge and a recommendation on a product that I think will not be harmful. Whether it will work for them, honestly, I feel like it's 50-50. So I'm not, 100% confident this product will work for you. So for instance, if you think of blood pressure medications, I'm 100% confident that that medication will help lower their blood pressure, but I'm not 100% confident that cannabis may help their pain.
Give me a percentage.
A percentage of how confident?
What percentage of patients will react well? How certain are you that your recommendation will be effective?
So, will be effective for the disease state.
For the disease, for a particular disease. I'm just looking for
I
general numbers.
I would say honestly 50%.
Okay, that's pretty good. That means 50% of people will probably be helped.
And what would help you be more sure? More studies?
Yeah, I think that, like, if you notice the studies, a lot of them used a variety of products in a variety of doses. And for me as a pharmacist, I like to know, the product and the dose that I need to use. And so I think more studies, knowing, the product to use and the dose to use is going to be the next best thing, for healthcare providers and for patients too, so that it's not a guessing game. And we're in the process in our clinic right now of actually publishing some of our, patient cases that we've been working with, just to provide evidence out there of, hey, this was what they used, and then this is how it really benefited them, just to provide something to the literature. Because if we just keep it to ourselves, then it's not getting out there for, other people to consider, or if they get funding to even, have a really large study.
So anybody else before I ask my last two questions? All right. My basic question is, why is cannabis better than opioids?
So I would say, due to the lack of long-term data that we have, that, just knowing that opioids can cause death, have led to death, cannabis does not do that. So I would say that's probably, number one reason. One of the reasons that we have this opioid crisis and that we're really trying to take patients off of opioids is because of the increased mortality and death that patients experience when they're on opioids, whether it's overdosing or, taking it in combination with medications. And I would say right now we don't have cases of, someone using like THC specifically or CBD and that causing mortality or death.
Would you say, a question of fact, are opioids physically addictive?
Yes.
Can you say that marijuana, in whatever form, is physically addictive?
Yes.
No.
I would
Not-
say, I feel like THC, I don't think all forms of marijuana are physically addictive, but I would say that there are reports of THC being physically addictive.
Would you say that that's rare? And Maris, you'll be next.
I would say that that is rare, yes.
Maris.
I would say that THC can be addictive, but not necessarily. I think it varies widely based on which body is imbibing. I mean, I smoked vast amounts.
You're being recorded.
That's fine. I was in India. I was in a state in India where it was legal, and I did a lot in San Francisco. I never got addicted.
And I think it depends on the patient. Just like there are patients who use opioids after surgery and they aren't addicted. They come right off of them completely fine. But then it's so patient specific.
It depends on the definition of addiction.
Well, I think that there's a behavior can be
Yeah.
a habit,
Right.
but the drug itself is not addictive.
You mean you think it's not physically addictive?
Right, it's not physically addictive, but you can have a habit
Psychologically addiction.
that you,
Psychological addiction.
yeah,
Do you think it's physically addictive?
want to smoke it.
I gotta interrupt because I want to run away,
Yeah.
but it's after 2:00, and thank you so, I want to get in a round of applause.
Thank you.
Thank you so much.
Bill, do you have a question?
No, that was it. I wanted to
Sorry.
interrupt and say
Scott, then Blake.
Wait.
Yeah,
Whoa! I've got one second.
I'm
We're
addressing
still
what
talking about physical addiction.
Okay, so you're up, Maris. Is that what
And
you're saying?
he has
I
a
would
comment.
I would like you to tell us, when you said, yes, THC can be addictive, were you referring to it being physically addictive? Or someone just liking to be high all the time?
So I think there are components in your body that can make you be addictive. So it would be like, for me, I think it's more of the psychological addiction. However, federally they view it as a very addictive product.
Do you
Because
believe
it's
that
a
it's
control.
as physically addictive as opioids?
No, I don't believe it's as physically addictive as opioids. Yeah.
That one actually is definable. Physical addiction means you need more and more, or a stronger or more potent amount to get the same effect as time goes on. Not true of THC. It is true of opioids. So opioids are physically addictive by that definition. THC is not.
Blake, did you have your hand up?
I did.
Go ahead.
So we deal with addiction a lot. There's lots of types of addiction. Love can be an addiction, okay, because it affects different parts of your brain.
Right.
Alcohol is addictive, okay. Have there been studies done for physical addiction for either CBD or THC, and what is the incidence of the general population that becomes addicted?
Yeah. So.
Not using Dr. Scott's definition.
Yes. So there have been studies. So I actually talked to some high schoolers about marijuana, and so I really looked into the evidence regarding cannabis use in high schoolers. And so in those studies where they specifically looked at marijuana, in high schoolers, they did say that it was an addictive substance. I don't think they really defined addiction, but did say that, students felt that they needed to do it every single day. And so I think, again, it depends on, at that point, your brain is fully forming, and it is really impacting your brain. And so I think there may be, a difference in using marijuana when you're younger versus using it, when you're older and your brain is fully developed and that why you're using it, if that makes sense.
So I hear you saying that they use it as a coping mechanism, But as you get older and develop better coping mechanisms, then you don't have that physical addiction or that addiction to it.
Correct. Yeah.
Frank, you're up.
I just wanted a round of applause for both Ralph and Dr. Fixen for just a great discussion. Thank you, Ralph. Thank you.
Chris.
Just regarding high school usage of marijuana, I've read that since marijuana was legalized, usage in high schools has gone down. Is that true? I guess that's all I want to know. Is it true?
Yeah. So I've also read that too, and I don't know if it's because, you know, it's in states where it is legalized, and so maybe they're using their parents' marijuana, or it's just not. They're going to like harder things. That's a potential like speculation. Like, oh, anyone can do marijuana here. Like, let's try something else. But I've read the same thing too. And the studies that I looked at in younger adults were specifically from like pre-legalization of marijuana. So it was from like 2011 to 2012 in younger adults. So I would say yes. I've read the same thing too.
Anybody else? And with that, Professor Fixen. Wow.
Thank
That
you.
was just,
Thank you.
you were not an evangelist, you were fact-based. I want to just say thank you so very much.
Thank you.
Very nice.
Thank you.
Great job, exactly. And with that, we're turning off our recording.